One, two, stop. Okay. So far today we've spoken about what addiction is. We've tried to gauge a good understanding of what addiction means today to all of us, where we stand with that understanding of addiction and specifically addiction in the Indian context. We've spoken about the characteristics of the disease of addiction and the consequences. Essentially, we've tried to understand addiction from more than just a layman point of view. Now, going one step ahead of that, once we understand addiction and we realize the consequences of addiction, not just to the individual but to his or her surroundings, which would mean family, friends, workplace, whatever it is. But the question is, what do we do about it? What do we do with treatment? Because if addiction is such a unique disease, therefore treatment also has to be in a way highly specialized and unique. Specialized in a way and yet not specialized in a way, which would mean that okay. Now since is the air conditioner working? Anybody's feeling cold, just let me know. Increase the temperature again. Now we have seen that there is a genetic basis for addiction, so that's the biological aspect. We've seen that addicts and alcoholics tend to have psychological vulnerabilities, probably from childhood. So there is that aspect. There is also the social aspect. The environment, is the environment conducive or is the environment not conducive for an addictive disorder to progress and worsen? So we call it a biopsychosocial model of treatment of addiction. This is the model which we say helps us to explain what causes addiction perhaps, but it also helps us to understand how to treat it. So when we target addiction, we target it from all these three aspects, not just through counseling, not just through detox, not just through physical containment. Yeah, so today, this is an overview of what we go through today. Stages of change. It's a process. Recovery is a process. So what are the stages which the client goes through? Framed as a brief intervention. The core assessment area. Now it's very important to assess each client individually, because every person is unique. Every person brings with them their own understanding of the world, their own coping mechanisms, their own emotions, their own superstitions, their own beliefs, their own genetic predispositions, the way they react to medication, the way they react to, say, a female counselor, for example. Things like that. Ending treatment. So this is like treatment in brief. Then I will speak about 1, 2, 3, 4, 5 specific kind of psychotherapies that are shown to be very useful in substance abuse treatment. So one is cognitive behavioral therapy, the most popular and also the most empirically validated, which means that research has shown that in substance abuse settings and in substance abuse with comorbid disorders, also with psychiatric illnesses, this has shown to be the most effective. Mindfulness or acceptance and commitment therapy, international humanistic psychodynamic therapies, and the conclusion. So that's what we'll do today. If I'm going too fast or too slow, please let me know. Okay, so first, we need to assess the treatment needs during stages of change. So at every stage, the client has different treatment needs. So for example, I get a client and I immediately jump onto him and I say, listen, tell me all your psychological issues, what's bothering you. He's not going to open up. Why? Because the rapport has not been established. So in pre-contemplation is when, particularly when the client is not motivated and he's just been brought in over here. So in pre-contemplation stage, we have to show the individual the link between the current problems in his life and the substance use. We have to just point out this link. Perhaps, don't say all your problems are due to substance use, perhaps there is a link between the current increasing problems in your life and your progressive use of substances. Contemplation is when the client is in conflict with his own beliefs and those being shown to him. Third is preparation. Preparation is when you sit with the client and you give him like a goal chart. What do you expect from treatment? Is it just addiction therapy? Is it personality change? Is it do you feel you have issues like low self-esteem? Whatever it is. So this is the preparation. So pre-contemplation, contemplation, then preparation. Then there is action. Action basically is post 15 days of admission, we enter this phase. So the client hopefully has finished the intervention. The client hopefully has he has an understanding of what he needs to do at least for the next 1 week. And then here's specific areas of the client's personality and his problem are identified. Because when a client comes to us, it's not just with addiction. He has psychosocial aspects. He may have an anxiety disorder which has been exacerbated, become worse by alcohol. We also have something called alcohol-induced anxiety. He may be having a lot of relationship issues not directly related to alcoholism, but which have become worse as a result of that. He may be having chronic low self-esteem, as mentioned in the last presentation. He may be having other medical issues. So the counselor and the counseling team works with the client in this period. Maintenance is relapse prevention. So what do you do after you go out? What is your maintenance program? Just like for diabetes, you have to maintain it and it will always remain under control. So in an addictive disorder, in order to maintain it, what are the strategies which the client and you can come up with, which will be helpful? Just a very brief overview. What is here? Okay, so frames essentially stands for feedback, responsibility, advice, menu, empathy, and self-efficacy. Frames is essentially talking about what kind of an approach would be helpful for a counselor in addition to adopt towards the client, any client. First is provide feedback on the patient's risk for alcohol or drug problems. You see, a very interesting thing. We get a lot of young clients who come to us with cannabis addiction. They are not completely aware of the consequences of cannabis because they say, oh, it's natural, it's this, it's that, it's everybody is doing it, it's not as harmful as alcohol, it remains in your system for less long, is what they come and say. Jiddu Krishnamurti has been talking about it. I have all his books and it's completely socially accepted. It's not as bad as LSD or cocaine or MDMA or ecstasy. But they do not understand that cannabis is actually far more harmful because still today scientists do not realize whether cannabis, see, alcohol, when how do you feel high, then you go down. It suppresses you, right? But when you have cannabis, sometimes it may take you high, sometimes it may take you down. Until today, even though scientists understand that there is a link between the cannabinoid receptors in the brain, which cannabis goes and blocks, we're not. Yes. Sorry? Yes. Yes, absolutely. But we're still not sure as to the exact mechanism that goes on in the brain. The responsibility. A lot of clients come here and say, I can't help it, I'm an alcoholic, you have to treat me. The fact is that the individual is not responsible for their addiction, they're responsible for their recovery. That's extremely important to stress. Advice basically involves giving direction. Many provided a variety of options for change. Empathy, okay, this is a very interesting aspect. Empathy, what is empathy? I'm being warm, I'm showing you that I understand you, I'm being reflective, which means whatever you say to me, I repeat back to you to make sure I've understood that. But in addiction settings, this kind of approach doesn't always work. At times, the counselor will feel the need to adopt a very firm and almost confrontational approach without being overtly negative. Because alcoholics and addicts are very good manipulators. So if you're always the good cop, the good counselor, who I'm always here to understand you, then you're fooling yourself because they are fooling you. You have to understand, you have to, with time, you will get an understanding of when to be firm with the client and when to be empathetic with the client. Okay, now when the client comes to you, what are the core assessment areas that we focus on? First is current use patterns. So we take something that's called case history. So we say, okay, in the last 1 month, what has the use of pattern of use been? History of substance abuse. When did you first start? 5 years after that, how much was it? 10 years later? And then you will see quantity will increase, frequency will increase, and substances will almost always get added to that. So, we also get information about major medical problems. Are you allergic to any particular drug? Or do you have a bad reaction to any certain medical procedure? Also, we avoid giving benzodiazepines to patients, to addicts and alcoholics, because benzodiazepine is an addictive substance. Health status, we don't admit patients who are not physically stable. So if the client is extremely physically unstable, then we say, okay, first take him or her to a hospital, get them medically stabilized and then come, because we have not a hospital per se. Information about education and employment. Support mechanisms. Who brought him? Is it his friends? Is it his family members? Are the family members aware? Are the family members supportive? Is it just the wife who is supportive? You see, when you get an admission, it is in a crisis. They will never plan it out and say, on 24th you will take him. On 23rd night, something big will happen. And in a state of panic and crisis, they will get him here. But you have the client who's being so-called forced into treatment, and you have the family who is in a crisis mode. But then what do? You have to ascertain support mechanisms for the client. Is the family, so this happens over a period of time. So post-admission, we actually speak to the families a few times and we try to understand, do they really understand what addiction is, or do they think it's like some black magic, or is it some psychological depression? So everything that we are talking to you about in this workshop today, over a desk, is actually explained to the families repeatedly, so that they understand what the entire situation is. We can also say occupational support mechanisms. Sometimes we have clients who are referred to us from their workplace, so which means that the boss is obviously very supportive. Client strengths and situational advantages. Previous treatment. People come to rehab as a last resort, usually. They've tried everything else. And if they have been to rehabs earlier, like for example, we get a lot of clients who've been detoxed and been hospital several times, had a 1 week or 2 week rehab program and they've been discharged. So we need to assess how successful, how long are we able to remain sober. Family history of substance abuse and psychological disorders, which means that a lot of the times we will see that in a client's family, we also have a separate family history session with the client. Is there a history of substance abuse? In fact, I want to change this slide because it's not just substance abuse. Substance abuse and compulsive behaviors. It runs along the same line. Is there a family history? Is there a family history of instability or diagnosed and undiagnosed psychological disorders? Because which means that this is a vulnerable client. We continually assess the client's mental status from the day he comes to the day he leaves. Okay, so the opening session. So what do I do with the new client who's seeing me for the first time? He's confused. He's experiencing loss of control because he's in a rehab and he can't go out. He can't make phone calls. He's probably withdrawing. He sees a lot of new people around him. First is to establish rapport as would be in any situation. So when I establish rapport, I'm not bombarding my client with questions. I'm just asking how do you feel, and I leave it at that. Most clients will take off from there, and by their rate of speech, by their body language, by the content of what they're speaking, you can get a very good assessment. Of course, this assessment will constantly change as they get more and more comfortable with you, but essentially in this session, you just let the client talk what he wants to. So like it was mentioned in the last session, you have to be the client's friend, yet not a friend. Which means you are a support to him, but you are not actually his friend. That professional boundary always has to be maintained, because then they will take advantage of that. Just like they took advantage of the lack of boundaries in family settings, which is why we also have a boundary setting session for family members as well. So identify, focusing and prioritizing problems. Now, you will suddenly be faced with a client who's got a lot of problems. He's got family problems, he's got mental problems, he's got physical problems, he thinks he has low self-esteem, he's feeling fear, he's feeling anger, there's a lot of things. So how does one prioritize what to go by first? First thing, the most important thing is the physical aspect of it. There has to be a complete physical assessment by a qualified medical professional to see that A, he doesn't have any physical problems. We take a complete blood test to see the state of his liver, pancreas, depending on his drug of choice. And see what is the current pressing problem for him. Often we don't really start so-called addiction therapy in the first 2 weeks. We just let the client attend the group sessions. So in the group session we have a lot of input sessions, other clients are sharing, and they look around them and they find that they find how the system is and they get more comfortable with it. Yeah. So making a treatment plan, I can't just make it on my own and force it onto my client because there's no point. Of course, if the client is a very compliant client, which some of them are, like, I want to be very good so that I can get discharged exactly 3 months, he may just agree to you. But a good treatment plan is made with the client's active participation. So you say, okay, I think this areas you can work on. What do you think? And he'll say, okay, maybe not this right now, but I think this is a more pressing matter. So you use your clinical judgment and yet you let the client feel involved and take initiative in his treatment. That will make him more motivated. therapy is always very structured. So there's certain number of one-to-ones, there's a certain number of group sessions, the family intervention is done after a certain number of days. The reason this is structured is because it is very easy to get carried away while doing counseling. Sometimes we sit with the client in a one-to-one and we spend 1 hour. That's not effective and it burns out the counselor. The ideal time is max 20 minutes and not more than that. So you start off by saying, okay, today we are going to discuss this. And the client will always go beyond the topic. Then you draw them back and you say, okay, we have 5 minutes left. Do you have anything else to talk about? Because if you don't do that, then the client will wait till the last minute and tell you, oh, there's something I haven't talked about. So, and at the end of the session, we always summarize what we've spoken about. And everything is noted down in the file. So, because this is under the psychiatric license, and we have a lot of patients with risk of high self-harm, there are psycholegal issues that we need to safeguard ourselves from by noting down everything we have done or said to the client. Okay. Yeah. This is very important. Making referrals for critical needs have been identified but cannot be met within the treatment setting. Maybe a client needs an MRI, so we have to arrange for that. Maybe a client needs continual psychiatric evaluation and assessment. So we always work very closely with the psychiatrist to ensure that our clients have input of psychologists, support workers, peer group as well as psychiatrists and of course medical physicians. Now, maintenance strategies. When we get a client, he or she comes surrounded by their own unique triggers. So we sit with them and we work and we try to identify what were the triggers in the past. Are these triggers still existing in the future? And if they are, how do you avoid them? If you can't avoid them, how will you handle them? So we have a very comprehensive relapse prevention plan. Triggers are basically, we focus on people, places and situations. We also tell them that for the first 90 days of treatment, there are 3 S's to be careful about. That is the sight, the smell and the sound of your drug of choice, because that will trigger it off. We do a lot of psychoeducation actually. Psychoeducation would essentially mean that we talk to them about all of this. So the client is equally aware of what addiction is. Since we follow a CBT model over here, which I'll be talking about in a bit, CBT, that's cognitive behavioral therapy, focuses on teaching the client to be their own counselor. That is what we aim at. So, developing a list of circumstances, like I said, situations, reviewing problems that emerged but were not addressed in treatment. This is a very interesting point. Throughout treatment, you will see that the client goes up and down and there are a lot of changes. There are a lot of, as the old issues get resolved, there are a lot of new issues which keep coming up. It may be past resentments, it may be some fears of relationships, it may be insecurities, it may be trust issues, it may be financial issues. So, there are some issues which we cannot resolve in treatment. For example, we get a client whose wife has left him. He is brought by his brother into treatment. But the wife refuses to come in. She will not take part in his treatment. but that is essential. We need her. But she's refused, and we can't do anything to force her. But that is a very big trigger situation for that client. But there's nothing we can do about that except to help you develop a plan to address possible problems in that relationship in the future. Again, coping with high-risk situations, parties, family arguments, fights, it could be anything really. Teaching the client how to capitalize on personal strengths. Now, as each client has got unique weaknesses, they've also got their unique strengths. So, as the counselor, it is our responsibility to understand and to pull that up. Emphasizing client self-sufficiency and developing a plan for future support. Mutual help groups, self-help groups, AA, NA, family support, community support, counselor support. Often when we get clients who are dual disorder and they're not from the city, we put them in touch with a counselor of their city and we say it is really important for you to continue engaging with mental health services, because as we all know, dual disorder and addictions are two sides of the same coin. One could affect the other, one could trigger off the other, and if you relapse in one, you often relapse in the other as well. Ending treatment, so termination should always be planned in advance. So say if a client has come to us 3 months or 4 months, which is the usually medically recommended period, we need that much time to work on them. So it is very difficult for us to cope when families suddenly come to us and say, okay, we're taking him out next week. Because we have planned the therapy and the stages of change in such a way that it's not rushed through. So termination of therapy should always be planned in advance. It will give you ample time and prepare the client as well emotionally for going out. Because you stayed for 30 to 120 days in a closed environment. You've gotten used to waking up at 6 in the morning for yoga. You've gotten used to your daily duties. You've gotten used to the people around you. You've gotten used to the social rules of the environment in which you are staying. So you need to prepare the client adequately for a post-discharge plan. Always leave the client on good terms. Even if the client is in lama, that's left against medical advice, which means that his program was 90 days, but after 1 month the family says, whatever, some reason maybe that we take him out, always let him go on good terms. So then, sense of hope for continued change. So he says that, okay, we're leaving, nothing we can do about it, but we hope that if you feel the need to be home, can come back to us. Leave the door open for possible future sessions. Here we talk about follow-up. So we do follow-ups. So when we discharge a client, we give them a date to come back within 1 month. Because in that 1 month, some new issues will have cropped up. Maybe relationship issues with the family, maybe not able to deal with their trigger situations, and so on. Then review possible. Yes, early indicators of relapse. So, a lot of people believe that you've been sober for say 3 months, you suddenly walk into a party, somebody offers you a drink, and you drink it and you relapse. But the thing is, relapse is not a one-time event. There's something called the relapse curve. When a client gets discharged, or when he first comes in, that's the beginning of abstinence, physical abstinence, he's here. happens, he makes some progress. And he'll go back a little bit. And at some point he'll get discharged. Progress, he'll go back. This going back these are the high risk situations. These are the dangerous situations. If these are not dealt with effectively, then the client will relapse. So how will he relapse? He won't relapse here. He will go here and relapse because then he will get on the relapse curve. It's not a straight line. On the relapse curve. First, I've been told in my relapse prevention plan to stay away from parties which serve alcoholic beverages. I don't listen. I say it doesn't matter, I'm going with my family. So I go. What happens? Sight, smell, sound. That thought starts festering in my mind. Next week, I go to work. I encountered a very stressful situation. And again I get the thought, wish I could just have one drink, just take one peg. Nobody would ever get to know. He goes home, he's tired, possibly hungry. Kids are not at home and he has a fight with his wife, a big fight. Because he comes home and the wife comes and kisses him. So then he says, "Oh, why are you kissing me?" She said, "I'm only kissing you to find out whether you had a drink or not." So he gets angry. He says, "First of all, I'm under stress. I finished a 3-month program. I'm working, I'm supporting my family. And then this woman is suspecting me even though I didn't drink." And he goes and drinks. So his entire mindset has changed because of that one initial thought. Throughout this, you will see personality changes in the client. You will see some very common ones are missing meetings, AA meetings, which we always insist that they go to. Increased irritability, increased isolation, and there is something called the HALT principle. So we prefer clients not to remain hungry, angry, lonely, or tired, because that would lead to a relapse. Common triggers. You will see that the person has started behaving like he would earlier when he was using, but he's not drinking or using right now. The behavior is the same. It's also called the dry drunk syndrome. Dry drunk syndrome. So he's not drinking, he's not using, but he's still irritable, he's still angry, he's still self-centered, he's still all of those things. Thrill-seeking, high impulsivity. You will start seeing more impulsive shopping, impulsive spending, saying things impulsively. So between going to that party and relapsing, there are a lot of warning signs which the family misses out on or the client misses out on. So to make sure that the early indicators of relapse are well identified, we put it in our relapse prevention plan as a comprehensive list of what could apply to them, of warning signs. And usually for each client individually, there are 5 main signs which are indicators of relapse. Okay, so I'm just going to go through what are the therapeutic approaches that we do. This is the most common, the most well-known, and most effective cognitive behavioral therapy for substance abuse. Basically, CBT is very, very simple. It's very simple. There's a situation. There's an interpretation of the situation in my mind, and there's an emotional response. Okay? out the window. There can be two kinds of interpretations. One can be, okay, that person not interested, this is a very boring section. Emotional responses, I feel bad, insecure, not confident. The second interpretation is that perhaps the person is listening and focusing. Emotional response, I feel good and encouraged to continue confidently. This is a very small, simple example of what CBT is. So in CBT, we teach that how I think I feel and how I feel I act. So thinking to feeling and feeling to acting. Please go back a little bit. Yeah. Now, with reference to substance abuse, and this thinking, feeling, and acting thing is it's the basic thing that we apply to everybody. Now, with reference to substance abuse, we say that, okay, substance abusers are deficient in certain coping skills which the other people are not so deficient in. For example, if I went and slapped you, okay, you would get really angry but you wouldn't show it. You would hold it in. And then you would keep like holding it in and replaying it in your mind until the next time you saw me. And even 5 years later, if you met me, you would still hold that in your mind as a resentment. That is the abnormal reaction. What is the normal reaction if I came and slapped you? Yeah. Just a small example, but so in the first situation, your coping skills with that emotion were maladaptive to you. How do we say, oh, I have good coping skills, you don't have good coping skills? If I'm not able to cope with day-to-day ups and downs and emotions in a healthy way, see, everybody gets sad, everybody gets periods of low mood, everybody feels high, but alcoholics and addicts, since childhood, and particularly when the disease is progressing, they are unable to handle the highs and lows. When they are sad, they are happy. When they are happy also, when they are sad, they drink. When they are happy also, they drink. So it's not the emotion per se, it's an inability to handle too much of that emotion. Deficient in coping skills. So CBT, what do we do in CBT? We recognize the situations in which they are likely to be emotionally compromised and help them cope with that. That is why we have one session all clients hate. It's called thoughts and feelings. And we have to sit and think about, we have to think of 3 thoughts. So what three thoughts did we have? So we make them write down the most predominant thoughts because we usually have about 60,000 thoughts in a day running through our head. So we make them write down the most predominant thoughts or significant thoughts in their mind on paper. And then we make them write down the associated emotions, the feelings. So newcomers will obviously have a lot of difficulty with this also because when you are constantly suppressing or magnifying or distorting your emotions with mood-altering substances, it is difficult for you to relate to them on the same thing without the mood-altering substances. But over time, as the substance is not in your body anymore, you develop better coping skills in therapy. That is what we do in CBT. A lot of people call additional emotional disorder, and this doesn't mean that it's only because of psychological problems that we have problem. This basically means that when you enhance an individual's coping skills, it is much less likely that they will use mood-altering substances to change their mood. first is called functional analysis, just a big term. Basically, this means that we have to identify what happened before and after you used. So that's why we have something called step 1 workbook, step 2 workbook, step 3 workbook. So how did you feel before? How do you feel after? How do you feel now? So we have to bring them in touch with their feelings. So when we can identify what was the triggering factor, I had a fight with my wife. Okay, was the triggering factor fight? Was it the wife, or was it the emotion that you experienced? So we help them identify that way. Coping skills training, this depends on client to client. There are so many ways of coping skills training. Anger management. For some people, counting 1 to 10 works. For me, it doesn't work. By the time I'm into, I'm just too angry. So for some people, other things work. We do things like visual imagery. We do things like gratitude lists. We do behavioral experiments, which is a big part of CBT. Like for example, we had a client who had a social phobia, anxiety disorder. So how would we deal with that? So we did behavioral experiments where he had to, and he was very nervous around strangers and women. So I made him go, and the person in authority. So I made him go by himself to a stranger who was a woman and who was a person in authority. So then he came and he went with a list of feedback, such as rate of speech, body language, volume of speech, and so on. It's a small way of doing it. Then he went, he spoke to that individual, and he came back, and she and he both rated him on that. And then you compare that and you discuss that with the client. So there's so many ways that you can work on individual coping skills with clients. Relapse prevention and all this. So basic principles of CBT, idiosyncratic formulation, which means that personal meaning. Like for you, this may mean something, but for you it may mean something else in your mind. It's a very bad example. Say you see a fight on the road. Okay. For you it may mean something else, and for you it may mean something completely different. You will be far more emotionally affected. So, what personal meaning does the client attach to that situation or that circumstance? Requires a good therapeutic alliance. It is very difficult to establish a good therapeutic alliance with clients who are very manipulative, who are resistant to change, who have many layers of personality. But we have to keep trying. Scientific stance, goal-oriented and problem-focused. So when I call a client for a session, I don't say, okay, now talk. I say, give me a list of things that are bothering you in brief, and we will explore them one by one. Because if I say, okay, now talk, then the client will take off and he'll spend 15 minutes on the first problem. And in the last 5 minutes, he'll say, oh, I have so many other things to tell you. So you have to direct the client. Emphasis on the present and aim to teach the client to be that time limited, which means, see, in outpatient services, we have CBT for say 12 to 14 sessions. So we try to fit everything within that comfortably. It doesn't go on forever and ever and ever. Usually CBT is quite time limited. Structured sessions, agenda. Normalizing. So normalizing is something which is used especially in psychiatric cases. Normalizing would mean that a patient says, oh my god, I see people around me and I get so anxious. Something must be wrong with me. What's wrong with me? That makes them more anxious. So first is you normalize the patient's perception of his or her problem. In whatever it is that you're experiencing, it is okay. We can work on it. And Sometimes the patient gets overwhelmed with their own emotions, but you will see this in psychiatric cases with psychosis who have some amount of insight into their problem. You will also see this in people with mood disorders. You will see this in patients with any of the disorders on the anxiety spectrum, be it OCD, be it panic disorder. So normalizing is a very important part. Often you will see when clients come to you, they have this fear, are you judging me? Some people won't say it and some will say it to your face. So no matter how much you ensure that your body language is empathetic and all, because of their own anxieties and fears, they will feel that you are judging them. So part of developing a good therapeutic alliance is to make them comfortable with their feelings. Okay, guided discovery and Socratic questioning. That's very interesting. How many of you know about this? Anita, you must be knowing. Yeah, so based on Socrates' method of teaching students, let me try to put that into the context of substance abuse. So when we get a client, and he's in complete denial, he says, my addiction hasn't affected my family at all. And in that case, it is not true. So you don't usually say, no, it's affected. You say, no, it's not affected. No, it's affected. You use Socratic questioning, you use guided questions, which will bring the client to himself say, okay, yeah, guys, okay, maybe, yes. So you say, so in the last 1 month, how often have you spoken to your daughter? 5 times, 6 times, maybe. Okay. Earlier, how much would you speak? A lot more. Is it because you've not tried to get in touch with her, or she's not trying to get in touch with you? Maybe because I have not tried to get in touch with her. Okay, so what's changed in this last 1 month? Will you give some reason? And you say, do you think it's possible that it could be because of this? Then you say, yeah, maybe. So it is a process of change. It's not that he's saying, yeah, my God, I'm an alcoholic, I need people to stay here for as long as possible. Nobody will say that. You have to, if this is a closed mind, you can't expect the client's mind to become open suddenly, even in 3 months. You just say, okay, consider the possibility of opening it just a little bit because you have nothing to lose. Just a little bit. So with that kind of an approach, you will see clients who are resistant to change often become more participative. So thinking, behavior and mood is addressed. I'm going to briefly through this. Mindfulness, we also do mindfulness over here. We have trained mindfulness therapists coming and taking sessions. Side note, we also have mindfulness exercises for people outside the rehab. We have these workshops actually. You can take more information from the reception. See, when we do mindfulness sessions with clients, we involve visual imagery. So, visual imagery would involve you are in a jungle and there is a stream flowing and there is leaves on the streams, whatever disturbing thought you get, you put it on the leaf, watch it flow by. It sounds a bit silly and childish, but actually it is extremely effective after a few sessions. Mindfulness basically involves paying attention to your thoughts and feelings without letting them affect you. Yeah, I'm feeling scared, but it's okay. It's okay. It's fine. It's okay to feel scared when I'm taking a presentation. It's okay to feel anxious when I'm taking an exam. See, they have many models for treatment. Psychologists, researchers are very fond of making models for everything. So, in mindfulness, we have a very good acceptance and commitment therapy model of treatment, which is actually shown to be very good in research, but it is contraindicated in those, which means not good for those who have psychotic disorder and also depressive disorder. So what ACT does not kind of change beliefs or reduce symptoms. This is quite different from CBT. It focuses on taking the beliefs less literally and disrupting the link with behavior. So in CBT, what we do is that we say, okay, you're thinking in a negative way, you're feeling in a negative way, so you're acting in a negative way. This is CBT. In ACT, they will try to change this part. It's okay if you're thinking negative. Just accept the feeling. Therefore, it will not affect your behavior. So this direct link they aim to do away with. So what is the key focus on? On changing the relationship with the symptoms. So the symptom here would be anxiety.
Next, could you give an example?
Sorry?
Could you give an example?
Of which one? This one?
Yeah.
So when I say that the key focus is on changing relationship with symptoms, if I will when we say symptoms, we are speaking about the behavioral aspect of it.
Right.
Okay? Or possibly even feeling. So somebody give me an anxiety provoking situation. What should I come up with all these examples? Just give me an anxiety. What would cause you anxiety?
Example.
Exam.
results.
Huh?
I said exam results, getting results.
Yeah, so exam. That is the situation. So what is your thinking? I'm going to fail.
Yeah, I have a study.
That's what happens.
So, in CPT, would you say, if you fail, what does it mean? That's how you forward in CPT. How would you
Let's just
forward
finish
it?
with ACT first. You wanted an example for ACT, right?
Right.
We'll finish that and go back.
Okay.
So
It's okay to fail.
Huh?
ACT, it's okay to fail.
No. It's
No.
not. When you say it's okay to fail, you're changing your thinking. In this, you're only focusing on the emotion. I'm feeling anxious. I'm feeling anxious. You're not changing the belief system. Here, I'm going to fail. It's a dysfunctional assumption.
Right.
When you say it's okay to fail, you are changing that assumption into a functional one. That is CBT.
So what would you do here?
You would not change your thought.
Accept your feeling.
Yeah, you would just say, okay, I'm feeling anxious. I accept.
But high anxiety would lead to some sort of behavior.
Exactly, that is the link that is to be broken. So, see, the way the anxiety curve is, okay, anxiety is not just a one-time thing. Okay, so in anxiety, what usually happens is, it is a curve like this. You start off over here. Max. For every one of us sitting in this room, we have the same curve, which means that anxiety starts, it goes up, up, up. In about 30 to 40 minutes, it reaches a peak, and then it naturally goes down. Right? So, what would happen is that this is the point at which you feel you can't handle anymore. It pushes your anxiety further, but it doesn't reach the peak. It stops here.
After that, you'll probably take a drink.
Yeah. Oh, whatever you like to do.
Huh.
But if you say it's okay, and you experience the anxiety, it will finish the curve.
So it's a 40 minutes of.
It depends on 30 to 40 minutes. It takes time. See, ACT is a very
Now I
strange
get
thing. Okay, so just to re-summarize in case anybody else has got confused. In CBT, what tends to happen is your anxiety comes, you say, oh my god, I'm experiencing anxiety. And you try to change the thought process. It goes back down. It will not go up. In CBT, you say, okay, I'm feeling better now. Instantly, usually. In ACT, what they say is, when you reach this point you can't take anymore, just say, it's okay, it's okay. Experience the anxiety, it will go up and it will come down on its own. Actually, ACT is a more healthier way of dealing with things. Same thing happens in obsessive compulsive disorder, right? So if they want to, we reach this point, and they say, I cannot handle the anxiety, I have to indulge in my compulsive behavior, or I have to indulge in my drink. Stops here, anxiety goes down, goes back down. But this is a maladaptive thing.
because you're repressing it.
Yeah.
But if you allow the anxiety to go and finish the entire curve, the goal is to make the person desensitized towards the anxiety.
That is a side effect of that. In some therapies, desensitization uses the same thing, definitely. But ACT doesn't concern itself with that.
What is the goal?
Just let it not affect your behavior.
So every time I feel anxious and every time I'm supposed to get my result, I'm supposed to sit tight for 15 to 20 minutes.
No. You're just supposed to experience it.
CBT is more intellectual, whereas
Yes.
ACT is more experiential.
Yes.
So when you experience the anxiety and you let yourself feel it naturally, it dissipates.
Yeah,
Is that what
exactly. Spot on. You want to continue?
No.
CBT is often for people who are too intellectually oriented. As a thing. It works better for them, but for people who don't understand that, so often an alternative of acceptance of internal experiences as just mental events. Okay, I'm feeling anxious. It's okay. And over time, the thing is that with ACT, you have to develop that. It doesn't happen the first few times. It takes time. Which is why it is not recommended for a lot of clients with comorbid psychopathology. So this is just the same thing. Visual imagery that we use with it, the same thing as mindfulness. So when I say imagine putting your thoughts, your anxious thoughts on a leaf, what you're doing is you're actually experiencing that anxiety. But after some time you will find that it is easier. Look at this now. Okay? Okay. Okay. Humanistic and existential therapies. Who is having an existential crisis right now? This is a little, it goes beyond all the CBT, CT, psychopathology and all, and it is more to spiritual, experiencing your human, who you are in a human way. The reason I put this here is because a lot of time clients get overwhelmed by the situation surrounding them. So when they get a feedback, so what we do is that their group members give them objective feedback. We have a format for that. So we look at the list of maladaptive personality traits and we say, oh my God, this is so much I have to work on. What do I do? This is one example of a situation which could overwhelm the person and cause what we term as hopelessness. humanistic and existential approach helps to help them look at bigger picture. In brief, in layman terms, that is all it is. So when we say that people have got psychological problems, it's because it is an inherent ability to make authentic, meaningful, self-directed choices about how to live. So this is not a very clinical thing. It's more focusing on. I don't personally very much agree with existential approaches, but there are some aspects of humanistic therapies which, when incorporated into a wide CBT framework, are extremely helpful. So, such as client-centered therapy, where the focus is on the client. We also use narrative therapy. Anybody has any idea what narrative therapy is? We call it autobiography over here. When a client first comes, we give them a notebook and a pen, because once they will be dogs, and we make them write an entire autobiography from beginning to date, from first memory to date. Of course, when Dr. Ravi speaks, he will also elucidate on exactly why we make them write the autobiography and how it is helpful. But it can also be called narrative therapy. Okay, let's psychodynamic approach. Yeah, we incorporate this. So when we talk about unresolved conflicts, symptoms that arise from past dysfunctional relationships. So during narrative therapy, when the client is sharing about a relationship with their father in childhood, you may see that there is a maladaptive relationship over there. And then suddenly you remember Freud. A lot of times, not just in substance abuse, but in all psychotherapy settings, you will find that you find clients who compensate or overcompensate for past relationships. It may be with parents, it may be with friends, it may be with extended family members, with siblings, with children. So we tend to explore that. See, this is saying manifest themselves in the need to abuse substances, but of course it's not the only reason. It is always the contributing factor. Past relationships and how we have learned to cope with them. The most important relationship we focus on is the relationship with the self. You know, we keep saying relationship with family is destroyed, relationship with work is destroyed, with friends, but the thing that has been destroyed the most is the relationship with the self, because the person is disconnected from reality, from their own actual emotions. Every time they feel fear, they think they are feeling anger. That is why we allow the feeling to be felt, let's process better. For whom? Yeah, so like I said, we can only use certain parts of humanistic and existential approaches because they're not very helpful to those who have coexisting psychopathology, which basically means if they have any mental illness. It's not helpful for them. Because if you tell a client who is on antipsychotics, encourage him to think about the greater universe and beyond that, it's going to start having religions. Those who do not need or have completed inpatient hospitalization or detox. So those who are physically stable basically. Those who are not physically stable should not be doing humanistic and existential. Those whose recovery is stable. So in the beginning only, you don't start talking to them about, okay, so there is this thing called, it's a humanistic approach, you hear more about it, I will make it sense. Those who do not have organic brain damage or other limitations due to their mental capacity. This, when you screen for this, there is there is a simplified version of CBT available for people who are compromised in this way. So, like I said, we have to tailor therapy to each individual's pluses and minuses. And a lot of the time, we find that we diagnosticians don't diagnose this properly. They think of it as a mood disorder when it is actually something else. So, in the treatment of substance abuse disorder, defenses are seen as a means of resisting change. Defenses such as, did this in the last presentation, do you think people
Denial.
Yeah.
Yes.
Yes. Why are these changes resistant? Because they inevitably involve eliminating or reducing drug use. So, how do you get past denial as a counselor, as a therapist? It is so difficult because you don't want to argue. That's not your role. So, what do? A lot of counselors I have seen tend to get into arguments with the client. But that is absolutely therapeutically incorrect. Because when you argue with the client, and the client will always try to draw you into an argument, then you are no longer a therapist. You're just a person having a conversation with somebody in denial. So, the following strategies are recommended for avoiding bad interactions around the client's use of defenses. And defenses can crop up anytime in therapy. First is working with the client's perception of reality rather than arguing. Like I said, Socratic questioning, giving leading questions, making them give the answer, asking them more questions, sidestepping rather than confronting defenses. So instead of say to an alcoholic, say, okay, right now you don't think you're an alcoholic, that's fine. Tell me about how your drinking has affected your relationship with your wife. And that they'll tell you about. But if you say to an alcoholic, denial will go up, blocks will come down, and the client becomes very closed to you. Then we use documentation from the family to demonstrate to the client how his or her denial mechanism is in action right now. So, summary. What we discussed today is stages of change, a brief outline of intervention. We have spoken about core assessment areas, how do you end treatment, what are the do's and don'ts, CBT, what is mindfulness, this I skipped, this I went briefly upon. I also did say that for whom, for which one, it's not, it's contraindicated. Oh, I forgot to mention, mindfulness and ACD also should not be used with clients who are on antidepressants or who have a psychotic illness. Preferably also not those who have an unstable mood disorder. Okay, we've talked about psychodynamic therapy. Any questions? Everybody exhausted. No questions? I can answer everything or nothing. Which one is it?
You're very clear.
Hope so.
Just as one is to mention PPP is people, places, and
Sorry, PPS.
PPS and
People,
situations.
places, and situations. And it's SSS. And halt, hungry, angry, lonely, tired. Triggers for anybody in early recovery. So there are handouts for my session. I think they are there. So I'll leave them later. Okay, we all need handouts later.
Could you explain about when do you know that a patient has really relapsed? I understood what you were
Has
trying to
relapse.
say. Relapse. Relapse.
In terms of active relapse, as in when they had a drink,
Yes. So, and
family calls you up and tells you.
how would you, for example, you just took a drink today,
Yeah.
and you probably would not find any behavioral
Yeah,
changes,
yeah.
and he does not drink again.
True. No, that will never happen. He will drink again. But I understand what you're saying. If he practices controlled drinking,
Yes. How would you differentiate between relapse and controlled drinking?
one drink is a relapse. Doesn't matter if you had before or after that, and you will have after that because it is a progressive disease. So if you are an alcoholic, you can never arrest your disease at any point. So even if you're not drinking, it is progressing. So if you stopped at 10, 6 drinks, you will start at 6 drinks, not 1 drink, usually.
Okay. And
That's how people get overdosed.
okay.
So yeah, in the first few days, the family gets a doubt, but they're not able to tell exactly. But after some time, inevitably, they will have proof, particularly with alcohol, a smell or the see, because it will progress very rapidly.
Right? Okay. I have a couple of more other questions.
You can ask me no problem.
Right.
Everybody's starving, but okay.
Okay. So basically the treatment method is such that their way of coping is drinking, right? That is how they are dealing with their high emotions.
Yeah.
We are taking that away and we are giving them an alternative form of
Yes.
dealing with that.
Yes.
Right. What if he does not drink, but he is unable to practice those new coping mechanisms that will automatically make him resort to drinking?
That's very possible. It's very common also.
Right. How do we go about doing that?
See, we can take a horse with water, we can't make it drink. We equip each client at his level of capacity to deal with it. So when he leaves, we make sure that he has the skills required. Some people choose not to use those skills.
Do we also keep a tab on the skills used? For example, when they come to the follow-up sessions after
Yes, we do. Yeah.
Okay, great. And the treatment is it's a holistic approach, right? Where you involve family, you involve doctors, you involve counselors and things like those. But there will be times when they'll also falter. Family will not be able to provide the kind of support that you're expecting the family to give to the patient.
This is post-discharge?
Yeah. Or even
We don't, I think I understand what you're trying to say. Family support is only till the point of understanding. Beyond that, they need to detach because whether he or she drinks is their responsibility, is that individual's responsibility. And individuals he knows where to get help because in the beginning of the relapse curve, he is aware. He just ignores it. So we have put in front of him all community sources of support. There's always us, there's phone calls, there's sponsors, AA members, everybody. Person who relapses chooses not to use those.
okay, they choose the easy way out.
Ultimately, complete rehabilitation happens when the person takes total responsibility for their for themselves.
Yes, absolutely.
You said when if they stop at 6, they always start at 6 and not 1.
Usually.
So then they stop at 6 and that's when they go through the whole program.
Yeah.
They're out. So you mean that is where they start
Yeah.
at 6? But isn't it not right for the body? Because the body is maybe
That's
not
why people
ready.
die of overdose or basically addicts. The body's tolerance has gone down,
Yeah.
but they don't realize that. So they start off at the last point they stopped. Which is why you will find a lot of overdoses happening in addicts. If you read up, if you've been following the news, you will see all these celebs who've been overdosing and dying after a long period of sobriety. That is what is happening with them. Oh, and the last point, when a person relapses, there's a lot of guilt and shame involved in it. So once they've relapsed, all their cognitive, distorted thinking, emotions, maladaptive, everything comes back, just comes back. He or she may not ask for help or seek help. But at that point, the family has to treat it as a crisis intervention and put them in an inpatient facility till they stabilize.
So that takes you back to our session 1. The low self-esteem and everything
Yeah.
stuff in this batch.
So relapse, highly relapse prone disease, unfortunately. Okay, everybody's starving. Lunch is served.
1 minute. Lunch है? देख मैं स्टॉप कर